meeting for rehab forum and planning committee meeting for June, what's today? June the 23rd. And it looks like we don't have any citizen address to the committee, so we're going to move to the approval of the minute. Item number 3.
Move approval of the Joint Finance and Planning Committee meeting from May 26.
Somebody to second, sir. All in favor?
Aye. Okay.
Any discussion, any correction? If none, any opposed? Motion pass. Item number 4, the update from our CFO. Welcome, Sharon.
Good morning.
Morning.
All right, got it going. This morning, I just have 2 items to update you on. The first one is the interim audit, which is my accountant's favorite time of year. It will start at the end of July, the beginning of August. They do a lot of testing to prepare to actually expedite the release of their final report in December. So we're looking forward to getting them started. We also have 2 dates reserved for you in July. The budget retreat will actually occur on Friday, July 29th, that afternoon. You do have July 22nd also reserved, but that meeting may be repurposed. So we're leaving that on there just for the next couple of weeks, and we will keep you posted on if that date is also needed. So I'm going to go ahead and move into the financial report if there are no questions. So for May, I will tell you, financially, we did have some catch-up items left, which I'll explain to you when we get to the income statement around contract labor invoicing. But from a volume standpoint, we looked very similar to the way that we have looked in the past. And I'll go to the trend graphs just to kind of help you visualize that. Our admissions are still remaining low compared to our budget, just slightly below last year. We have still a higher case mix index as well as a higher length of stay occurring around those admissions due to acuity. Our key outpatient statistics, we do have a similar trend in the emergency department. You can see for the last 3 months, those volumes have been relatively constant, as well as in the urgent care visits, which are above budget. Our primary care visits are slightly down this month. We do have some provider vacancies. Again, this was for the month of May, but year to date, we're still slightly down. However, our specialty clinic visits are busier than we expected when we created the budget, and those are about 5% over year to date.
What is in the specialty clinic? Can you remind us what area that is?
So the specialty clinics are all of our outpatient clinics with the exception of the surgery. So it's really small print, but it's cardiology, oncology, and women's health. It does exclude the behavioral health clinics, which we show care visits or capturing all of our primary care as well as some of our school-based clinics. For surgery, we have had a nice ramp up for inpatient surgery. Although we're behind budget by about 6%, you can see that we are above last month and last year. Our outpatient surgeries remain pretty high. As you can see by the blue graph, they have maintained those volumes for about the last 3 months. And for behavioral health, we're showing patient days. They're slightly behind year to date, about 3%, but relatively constant with the prior year. Our clinic visits remain strong, and our emergency visits are, even though that graph is showing yellow for the month, it's actually right on budget. We're just about 5 visits under. Some of our financial metrics, again, some of these look different than they have in the past, but if you have any questions, I'll be happy to go over them again. Our payer mix, again, that drives a lot of what we expect to collect from this month's activity. And those slight changes month to month do have a big impact on the income statement. Our FTEs per adjusted patient day in the top right, that is favorable. Our budget is the rightmost column at 6.1, and you can see we're running at about 5.9. However, that is hours paid. When you convert that into dollars, you'll see on the next few pages, we're still incurring some really large and unfavorable rate variances for our labor. Those overtime rates and shift pay have remained high. And then on the bottom right is our connection enrollment. We did see an uptick last month, and that has pretty much maintained for the month of May. We're still just above 40,000 members. So for our income statement, I will say that one of the big drivers this month is down in our contract labor line. You can see that we're about 4.7 million over budget. That has been the trend for the year. However, there's about 3.5 million of that 4.7 overage that is related to prior months. We really started to have some contract labor begin to escalate back in January, and that has continued to escalate. And during the month of May, we worked very closely with our vendors to make sure that we shortened the timing of the processing of those invoices. So that is kind of a year-to-date catch-up, and then we should return back to the normalized contract labor for the last quarter. So that's kind of a catch-up, if you will. Our operating revenues are slightly under. Just a reminder, as we saw in that first page of graphs, our inpatient volumes have been down. And even though our CMI is slightly up, there's still a large inpatient gap for the collected dollars on that. And then just again, to prepare you for the last quarter, we've had the benefit of the HRSA funds, which pay a Medicare rate for self-pay COVID positive patients. And that program ended about 6 weeks ago. We are seeing some dollars trickle in, but those are really starting to slow down. So I am guessing that if the trend continues, that gap will remain for the rest of the year. We did have a pickup in other operating revenue of about 3.7. The tobacco trust revenues that are allocated across the state of Texas to providers, we got $3.5 million more than was in our budget. So that was a nice pickup this month. So overall, when you go down to the bottom, we've had a net income or operating income of about $3.4 million compared to a budget of $9.5 million. That is about a $6 million gap. However, $3.5 million of that was related to a prior month. But even if you look across into May, we closed at, and this would be for the 8 months ended May, right at $58 million. Are there any questions on the hospital?
I have a few questions for you. The $2.1 million for the net patient revenue
Yes.
fees, is that related to booking of the allowable amount, or is that something else?
So let me see if I can repeat your question and then try to answer it. So I think you're talking about the $2 million gap that's up in net patient service revenue. That $40.8 million is what we consider to be the collectible amount from the charges that posted in May. So that should be net of any write-offs that we see coming. Is that your question?
Right.
Okay. And a lot of that gap is due to we budgeted a higher inpatient volume than is actually coming through. So the inpatient activity is causing a large part of that gap this month.
Do we have an idea of why our inpatient number is down that low?
You know, if you look back, a lot of our inpatient volumes come from, I went too far. Our emergency department visits are slightly lower. And if I had a 3-year trend, the ED visits would be much higher in 2019 than they were in 2020 because patients just changed the way that they access the ED after COVID started. But a large part of those admissions come from there. We're also pretty aggressive in trying to keep our inpatient admissions down. So we've created some new programs around at-home care. And, you know, the telehealth that we are continuing to see will hopefully the at-home monitoring that comes out of those visits are hopefully controlling that. But when you look at the admissions, even though we budgeted for those amounts to be higher, they're actually trending very close to prior year.
We don't see it here, but do you see the uptick in observation stay?
So we've got lots of work groups. I can't see Colin through the back of my head, but he's probably giving me a big thumbs up. We are working very closely with our providers on how we are documenting and determining what qualifies as an inpatient versus an observation. The observation cases will not be included in the admission graph as I'm showing it here. So as we get those patients more properly placed, I believe that we'll start to see an uptick in the admissions.
Yeah, I just want to make sure that,
Yes.
that we do a lot of transformation and all that stuff. So,
Yes, sir, it's a great question.
regarding to the emergency visit versus urgent care,
I'll go back to that graph.
is there something here that we can derive from that maybe they do a better job of steering patient to the urgent care, or?
So there are some work groups around that as well. Dr. Duncan, did you want to address that?
It's interesting that you asked that question. I just met with our CNO today, and they are creating some criteria for the urgent care to be able to take care of some of that low-level chest pain, and so that we can drive a lot more of it to urgent care. So there is some of that, and less drive from urgent care to the ED. So just to your point, having some good parameters on who is best seen in the urgent care. So there is work that's going on with that.
I actually like the trend. I just don't like the revenue chart, but I think it's set us up better to go to value-based care, so we can start taking a little bit more risk on that side of it.
Yes, sir.
I feel the same way. I love the fact that our outpatients going up, our urgent care is going up, and our ED visits and our inpatient visits are going down. So I think it's
The other question is around behavioral health patient days and the outpatient behavioral health admission for outside medical facility. That seems to be going up. And is there a concern here that we need to take a look at?
So we have worked on the behavioral health, the outside medical services for quite a while, because these patients, if I recall, have anywhere from a 5 to 7 day length of stay. As our behavioral health emergency visits increase, again, a large part of our admissions come from the PEC. And then, so as you see that uptick in that bottom left graph for the emergency visits, there'll be an overflow as we reach capacity to our partners that we use in our outside medical services. So for the month, I don't think that that's surprising. We've also seen an increase this year for the patients that we have in-house, they've had longer lengths of stay and have been more acute. A higher level of psychosis, I believe, is the terminology that Zelia had conveyed to me. So there's just a lot going on with behavioral health. We don't really show the acuity of the behavioral health patients, but the ones that we have in-house are having a longer length of stay at a higher level of care. But we have teams also that are really managing those behavioral health admissions at outside facilities.
Go ahead, you've had your hand up longer than mine.
Sharon, yeah, we just accepted a given. I know you talked about on the connection program that the things that you're doing to try to increase and enhance that. But it just appears that it's staying around 40-some thousand.
Yes.
So have we accepted that maybe that's probably where we're going to be?
I don't know that we have accepted. I think we are still trying to figure out how to reach pockets and individuals. I know Michelle Haynes and her group do great work around trying to collaborate with organizations outside of JPS. Traditionally, I think our focus has been to really manage the patients who have been accessing care here at JPS. And DT and I have had lots of discussions around, what's going to be the next steps of us going out and trying to contact those individuals who are not yet accessing care here at JPS. I don't know if that answered your question.
Yeah, it does. I guess I myself am trying to, just the individuals that I oversee, I guess you'll say, I try to push the connection program. But one of the things I think I need to do is that if I got a pamphlet or something, so when they come in the door, they can pick it up, I can say something, and even put it in my newsletter, because I know that there are persons, I'll just say in my church, that could use the connection program. But I just don't think that they're understanding or accessing or know how to access it. So
Reverend Emerson, we can definitely get you some literature that we already have and work with you around that.
We'll give you the packets that we use with our connection. And Sharon makes a good point. First of all, I want to say I do not like the flat 40,000 that we continue to talk about. I think we need to understand what our capacity is, how many we actually can see based upon the number of clinics that we have, the number of staff that we have. I think we can see more. I think we can have within our kind of population of JPS connection a larger number. But right now, we have to do it a different way. As Sharon said, we are waiting till they come and hit one of our doors before we determine eligibility, and not all of them are eligible for JPS connection. They may be eligible for Medicaid or Medicare. So how do we now start that eligibility out in the community so that they're not getting sick and showing up at our ED, but are able to have a preventative care, PCP, and receive their just primary care in a clinic. So we've got a lot of work to do around that, Reverend Emerson, and I've heard you say that for a number of years, and so we are working through that. And I appreciate you keeping that on top for us.
Let me see if I can give some color highlight around the connection population. Even though we see 41,000 in here, we actually have more because the churn
Sure.
go in and out. And
Yeah.
at some point in time, when you do a cut over to report, that's what you see, about 40,000. But for so long, the whole program was to provide another methodology to pay for the underserved community. We're not actively going out there like a health plan to enroll people. That requires different skill set, different compensation, and then how many can we scale up and train. I think that will be some part of the visit that we may see for the budget for next year, because you
Yeah.
have to start out and then you
Yeah.
can grow the size of that. But it's different compensation. They show up, we provide excellent care, provide them the right enrollment and everything else. But if we don't see them, or if we go to a health fair and all that stuff, we don't know what to do with that. It's
True.
It's a foul up the marketing and all that stuff also as well.
All right, thank you.
I have one question before you move on for your statistics.
Oh.
On your occupancy rate at midnight, does that include the behavioral health patient aids patients?
No, this
Okay.
is medical surgical only.
Only, okay.
On this page, it's all med-surg patients and does not include behavioral health.
Okay, all right.
All the
thanks.
behavioral health activities on that one page.
Okay, all right, thanks.
And that occupancy rate, by the way, is very high.
Yeah,
Because
that's-
of the way that we're turning patients over and,
Okay,
Yeah.
all right.
Yeah, I have a behavioral health question, but it doesn't maybe pertain to the
okay?
budget. And I don't know if I'm out of order asking this. Our behavioral health patients come because someone decided they needed to come. Do they have access to JPS when they feel there's a need? I don't know how to frame that question.
Yeah, so if you're feeling really bad or suicidal, do you have the ability to walk in yourself? Is that the question?
Yeah, yeah.
So they do, and our psych emergency center sees quite a bit of that actually come in by themselves. And then we have those who are much sicker that may be brought in by the sheriff or by a family member. So we also see it, we have an outpatient center that also has same day, you can pretty much walk in. And then also within our primary care homes, they're being addressed if they come in. And there are some behavioral health counselors that are in many of our sites, so that we can quickly get them assessed and moved to the next place of care if needed, or to be able to be cared there. So there are many ways in which if you are feeling that you need just mental health, can enter into our system. And it's interesting, the community knows a lot about the psych emergency center, so that often is the place in which most individuals come to.
Okay, I didn't know that, and that's good to know. So I can talk to you offline with that, just on how we can market that. And I say that just based on what you see in the environment today, that it's a mental health problem more than we got the medical side of it. So
I think there's a lot of stuff that, the whole community healthcare is moving toward to get a better understanding of that. I
Yeah.
believe, I haven't talked to Zelia, but I believe she started collecting some of the non-reimbursement data for social determinant of health, so that you can see, you report but you don't get paid, but at least you understand and start looking at to see if there's family related that have certain
Oh, yeah.
condition and all that stuff, so that you can have early warning, you can use your care manager and all that stuff. I think it's at an early stage to start collecting those code, and how we use that will remain to be seen, how much we can apply and move forward with that.
I don't want us to forget that if you have a primary care doctor, whether you recognize it as being a mental illness or behavior health, you still call your doctor, and, a lot of time it shows up in young folks that I'm tired, I'm just not feeling well, and they call for an appointment for that. And so you're looking for your primary care doctors to also identify that and send them over to behavior health. So a lot of times when folks call me and say, I just don't know, I said, why don't you just call your PCP and see if you can come in for a visit, because they should be able to.
Okay.
It's easier for them to go that route than trying to walk in sometime and get an appointment.
Okay, good.
One quick question around pharmacy. I think they're doing a good job with the specialty pharmacy and all that stuff. Do you know if they are looking at more from a catchment area so that we can help the population with the 340B, access to 340B and all that stuff?
DT, I don't have the detailed information that you're probably asking about, but we can work with Nicole, and we do aggressively try to access 340B wherever we can. Again, 340B is outpatient only. It has to be filled at our pharmacy, and it also has to be prescribed by JPS physician. So once those three things match up, we're really good about making sure that those savings are realized. And it's a huge number for JPS.
That can be a little bit picked up if we look for additional revenue type thing. Okay.
Yeah.
All right.
So for a claim, this month, both month and year-to-date, their encounters are over by about, or down about 2%. So they're right on budget and tracking, for the most part, slightly above where they were in the prior year for most months. At the bottom right page, you can see an operating expense per encounter. If you look at it year-to-date, it's favorable by about 3.5%. So it is costing us a little bit less per encounter on the expense side. And then from a operational month in May, it really, a claim has been performing very, very similarly for about the last 8 months. You can see that they are slightly over in net patient revenue. Some of that is due to the mix that they're experiencing. We do have a little bit higher specialty volume than we do in primary care compared to the budget. And then in salaries, you can see overall, the salary number itself is lower, but we do have a little bit elevated contract labor, but we also have some savings in the other operating expenses. So they performed about $1.1 million favorable to their budget, and year-to-date, they're $8 million favorable to budget. So nothing unusual to report for the month there. And then when you look at our consolidation year-to-date, we have fallen short of our planned budget of $39.6 million compared to the actual performance of about $37.3 million. So we'll be working to close that $2 million gap over the next 4 months. Are there any questions around May?
Nope, just a footnote for our budgeting. We need to budget much high expense for the CME stuff, because airplane and all that stuff is so high.
You know, I'll just take note of that, and we'll work on it for
Because we
budget.
can't just use last year's number.
Yeah, so interestingly, the CME pool here in Acclaim is an annual number, and regardless of how we try to trend that over the year and spread it over the months, we never quite can predict it completely. But those are pools that the physicians have to use for CME, yeah.
Any,
So I think if there's no other questions, I would be requesting approval for the unaudited financials for May.
I forgot, do we, oh, we have to have a vote?
Yes.
Entertain motion, second.
Thank you.
All in favor? Opposed? None. Motion carry. Item B for you again.
So item B is the long-awaited reimbursement resolution we have discussed in prior months. It will be approved by the full board next month, but we wanted to bring it through the Finance and Planning Committee as a recommendation and referral up to the full board. This resolution, we worked with Bob Dransfield at Norton Rose and Fulbright. This is going to allow us to go ahead, and while we're working through the bond issue process, which can be 7 to 9 months, anything that we're expending on the identified projects, which this is related back to the Phase 1 projects, and they're listed here. It allows me to go back and, once we get the bond proceeds, to reimburse my operating cash for those expenses. On the last paragraph, you'll see the obligation is $550 million. However, we are planning to use some third-party financing on some of the projects, such as the medical office building in Phase 1. So I don't anticipate that the bond issue would be the full $550 million, but based on our legal counsel recommendation, we wanted to go ahead and put the full amount into this resolution.
Any,
Okay.
just,
Make sure I understand. We're going to do this amount, but for one of those, for the medical office building, we think we're going to have a partner with that.
Yes,
So
ma'am.
even though we are going to recommend this maximum amount, we might not be selling that many bonds.
Correct.
Okay.
Yeah, so the reimbursement resolution, you know, it's one consideration, and it's one point in time. So Bob Dransfield really felt like we needed to include all of Phase 1 expenses.
Okay.
The evaluation of what we issue for the bonds and finance with the bonds is a separate consideration that will be done in the future.
All right, okay, thanks.
Yes, ma'am.
Thanks for clarifying that.
all right, with no further question, entertain motion for approval.
Move approval.
All in favor?
Aye.
Opposed? Motion passed. Item C, Mr. Mendenhall. Hi, David.
Good morning.
Morning.
So first of all, Dr. Duncan, I'm not going to steal your thunder, but just want to introduce Will Showalter, who's in the back here. He is our new Chief Information Officer, and right back there. So you'll be seeing a lot more of him at all of our board meetings as well. So
You must be coming here for the heat.
yeah, he definitely came here for the heat, and then he made me sit at this chair to be in the heat with you guys, so it worked out well. I bring two contracts to you all this morning. The first one is with a cybersecurity company called Synergistic, and Synergistic over the last several years has been helping run our cybersecurity program to develop the maturity of it and also to assess the maturity of it. So not to steal anything from Colin of things he's going to be talking about during our governance committee, but one of the reasons why we've seen such an increase in our maturity from a cyber perspective is working with this organization, Synergistic. So this is a renewal of the next 3 years working with them. One of the things I will highlight that we have added with this particular contract is our medical device security program. And that's something that we have not been doing in the past. We've been doing it on our own, but we have never had an assessor come in to assess the maturity of that medical device security program. And we're going to be doing that over the next 3 years to build that. So I put that in front of you for your consideration.
David, is that the same as, we have it listed as CTEC?
Yes, CTEC, yes. They're CTEC synergistic as well. One of the other things I will highlight during the RFP process, we asked CTEC synergistic to go back and they're an Austin-based firm, and so they know what we do here in the state of Texas when it comes to working with diverse vendors. We asked them to go back because the previous 3 years they did not subcontract anything to diverse vendors, and we asked them to do that this time, and they were able to find just short of 10% of the contract to be able to work with a diverse vendor to be able to do that, and we're going to see more of that. And that was a push from us with a well-established vendor, and it worked out really well. So put that into it as well.
Okay, I have the,
Question for both companies. Then, are they new?
No,
So
they've been around synergistic. So
I mean, with us, is this their?
no, they've been working with JPS for, I believe, close to 4 years now.
Okay. Then my question is, how is it that they can't comply with our NBWB policy?
This is the first time we asked them to do that. And we asked them to go back and make sure that they were complying to what our goals of the organization were. Prior to this, if you look back in the board meeting minutes 3 years ago when we asked them, we didn't have that push. And I remember you asking those questions during that time, and that's why we pushed them this time to make sure that they had an effort. Finding cybersecurity vendors is not an easy thing to do. It's not something that we can just go out and find. We have to find credible people that can really do this done for us.
Okay. I guess I'm just uncomfortable because if you knew it beforehand, I'm not saying to you, I'm talking about the company,
Right.
and now you're back to us again, and we still haven't made a step. I just have a problem with that. I guess my concern is how companies continue to say we're working at it, but never achieve it, and so we just keep accepting that they're not complying with our MBE policy, WBE policy.
I think one of the things is 3 years ago, we accepted that without saying anything about you will do it. This time, the person that is responsible for the contract came and said to them, you will have some diversity. They didn't get 25, they came with 10. In the past, they've been coming with 0. So I do appreciate that we are now focusing on it, and that's a step for us. It is because we, the person that is doing the contracts, have been okay and not asking that we have continued to not get it. So the board has put more emphasis on that. And so now the person that's doing the contract is finally hearing that. I also thought when we did the group purchasing group that they was going to help us identify diversity companies that could actually work with us. And there was a report that we could get showing this contract came, these were some diversity, you elected not to use them. So we put something in place to help with that. And I am glad to see that we are at 10, would expect to see it to move forward. And I would still think that on that contract, I would like to see how many of our contracts are we just saying we can't do any subcontract, and we accept it, and that company have shown us that there are some diversity vendors. I'd like to see that report to make sure that we are following our process. And I
no.
do thank you for
You bet.
at least asking.
And just for instance, I appreciate that, Ms. DeVos, because when we got the RFP response from this particular vendor, they did check that box. We can't subcontract, right? And I had immediate conversations with their CEO and their COO saying, not acceptable. If you want this contract, there's got to be something you can find. And they were able to go out and really, we're very proud of it. Not only that, but we were able to vet the people that came in, and we're really happy that this organization is going to be coming in to help us with that.
So are we talking then to the company during the process of the contract, or we wait till a renewal of the contract to talk to them? Are we talking to them, if we agree to this contract, then, and they are in compliance, they're saying what we're trying to be? Are we talking to them during the to get an update on you're trying to be in compliance?
Yes, with these long-term contracts, if it was a 12-month contract, it'd be a different situation. But this is a 3-year contract, and we will be working to push that number through all 3 years, right? This is a guarantee for the first year, but we'll be pushing them for the second and the third year as well to increase.
And then we get a report from them where they are.
Yes.
Each year.
Yes.
So, and what if they're not there? What do we do?
We have an out clause, right, with all of our contracts like this.
But we have to be very careful though, because when you deal with cybersecurity, IT and all that stuff, first of all, we cannot eliminate people that we think is the best first, because we have to protect the integrity of the institution first. And then once they fit that criteria, hopefully we have a few to choose from, then we have to address the diversity part of it. Otherwise, we disqualify some of the best group to protect the integrity, and then we have a bigger issue. Ransomware and all that stuff will shut down this place very quickly. Yep. And it can be, especially we're in the trauma level 1 facility. If that thing shut down, we can have death in the hospital without knowing. And
I think DT,
be very sensitive for that.
I think we are sensitive to it. We've been too sensitive to that, that now we're saying this is what we are requiring. And it's amazing they can find one that they are happy with. It is because we are requiring it, and that person that's bringing the contract to us is putting some emphasis on that. I don't think that we are going to put ourselves at risk, but we are saying to them, you know companies, you will bring them, and now they are.
One thing, can you, I think this is from my education also as well. When they fill out the form and they say they have diversity, for me, diversity should be for, what's the right word? They have to be here in the U.S. because we want to stir the economy, and also making sure not somebody on H-1 visa type thing that will fit that diversity, because that doesn't really address what we're trying to do. So I want to make sure that we just don't look at it and say, oh, they have diversity, but majority of them are halfway around the world.
Yeah, that's an excellent point.
So
that's an excellent point.
Reverend Emerson, to your question, we are getting to the vendors who are interested in responding to the RFP early on in the process to set that expectation. So it's basically, do not submit an RFP if you cannot get close to what we are asking, and you will need to defend if it's below 25%. So we're getting earlier to them so that we're not getting, 5 or 6 responses that have not worked through that. To Dorothy's point, I think there's probably still some work to do on our side to make sure that we understand who are the diverse vendors within this space, so that if they say that they're having difficulty doing it, we can match them with them, or to let them know that you are not in a space any longer in which there's not diverse vendors to partner with. So we are having those discussions with the vendors, and we will get better. I will say that IT is one of the hardest, but to your point, there are now more opportunities, and we have and to Dorothy's point too, we've written it off as IT is just one of those in which we're going to say that there's not diverse vendors. And so I want to commend David for saying you're going to go out there and you're going to have some diverse vendors before we're going to even consider moving forward with that. This is a lot. With cybersecurity, I do want to give credit to David and his team. I mean, we probably have one of the best operations around our security, our cybersecurity. I always say to David, the rest of the world may get hit and they all be in the dark, but JPS will be up and running.
Just remember we're live streaming Dr. Duncan, and attacks are going to happen right now.
He will keep it running here, but they really do monitor it. He knows when the chatter's going up. They know how to get in there and to really keep it going. That is a huge operation. So
Not promoting hackathon here.
No. We're not going to do Hackathon 2022 here. No.
I thank you for that. And I want David to know, too. He knows. I'm not throwing the ball at David because I know he works to make sure compliance is in place. It's just because I know that if a vendor's coming, David says, hey, Reverend Emerson's going to ask this question, so I got to be ready. But I just want to echo, hoping that those vendors are tuning in, that you just can't just take us for granted and we accept the paper.
Yeah, agreed.
Yeah, that's my concern.
Agreed. And a lot of it, again, we're getting into the weeds here on our vendor negotiation. A lot of it is legacy vendors, right? Newer vendors that come in, they're expecting to have this type of thing. What we're working now is going back and educating these legacy vendors that we've worked with for years, right? Some of them decades, and actually the next contract, right, with Infor, we've worked with for decades, right? Our master services agreement, and I know we haven't taken a vote on this, but doesn't have any of this type of language in there. So we've got to educate them in future years, and not, what we've done in the past. Right.
Let me ask you a different question, because some area is going to be very difficult for them to meet that requirement.
Yeah.
Because, job market, people sometimes get paid, they can be partner track and all that stuff, so it's very, very difficult to go to a smaller company or environment to do that.
Right.
What if we find a way legally, if they don't hit the certain criteria, they can opt for a certain penalty so that we can fund some diversity program that we can help the community and other stuff. Would that be something that can cause some headache on your side?
I don't think it would cause some headache. I think we would be up for the challenge with that, right? And to even help maybe even train the next generation of these, much like what we have a fellowship and an intern program for leadership and for clinical studies here at JPS. Man, wouldn't it be great for us to partner with Tarrant County College or with UNT or something else like that to bring in some of the next generation of the cyber, because what we're finding in the marketplace right now is a very young, immature generation that wants to be at those hackathons, but doesn't really understand the business rules and complexities of what you're doing to make sure, you can't just turn something off, right? There may be some reasons. When we were talking about this program that's going to be doing for medical device management, we had some early people that were in there, again, nothing against 20-year-olds, 22-year-olds, but they would see something on the network and want to just turn it off. And that was an infusion pump that we were, sending information to, right? We've got to have the business context around it. And if we can be in that opportunity where we can train that next generation, I think that's going to really help not just JPS, but it's going to help a lot of industries, because healthcare is so complex right now when it comes to cyber. Everybody wants a piece of us, and every day I turn more and more gray. So it's tough.
I did have a question quickly, not to
Yes.
prolong the discussion.
You guys are short on your meeting so far, and it's just smaller agenda, so I expected to get abused. It's
Okay.
fine.
I'm just curious as
ma'am.
to what is the expected scope of work for the medical device security program?
Right, so no, great question. So we're going to go through, and since we have never done an audit on this, right, year one is to do complete assessment, find the gaps, do a complete risk assessment across all of it. We have over 10,000 medical devices that are connected and producing a lot of data, right? Over the previous years, what we've done with those medical devices is separate them onto their own network, right? Whether that was good, bad, or indifferent, at least the data was not intermixed with the rest of our network, right? So that was kind of like DEFCON 1, right? I mean, just push it over so nobody else can see it. But what we've got to do now is to make sure that that own network isn't causing its own problems. And so that's scope 1, or year 1, is to do that full risk assessment. Year 2 then is to take those recommendations and start implementing some very strong programs and technical security around that. So that one, and here's a contract you're going to see about 6 months to a year from now. Our expectation is to be able to identify every piece of software that's running on our network and be able to tag it as hostile or friendly. And those 2 tags they're going to be able to say whether or not it's allowed on our network or not allowed on our network. And the mobile device security things are going to be able to help us identify those pieces.
Let me ask you this. Since we're talking about IoT and all that stuff going on there, do we have the capability to ping them on a regular basis or, audit them to make sure that they don't just load it up and using the SOC 2 Type 2 compliance from Amazon, AWS or something, and then left all that security open and we don't know about?
Yes, we do. So we have several stops in place for that, right? So, for instance, when we're working with outside vendors, like, one of the complex vendors we work with is Maxor, who manages all of our pharmaceuticals, right? So we have several stops in place because their people are intermixed with our people and their technology is intermixed with our technology. That brings a whole nother set of headaches that we have to work through. And so we have several stops in place, whether it's an IoT device or whether it's a vendor's technology on our network to make sure it's behaving the way that it should be behaving, doing the way that it should be, what it should be doing, and the ability to turn it off if it's not.
Okay. Sounds good. Any more questions, comments?
I just have one question, not on this item, but just to Dr. Duncan. Is it possible the prior CEO tried to bypass this when I asked this question?
I'm not responsible for anything that has occurred before my time.
And the
For
prior
December 31st.
and the prior legal counsel also tried to, on the sheet, when it explains the 3 areas, the compliance or good faith effort, but the next, it says goods and services in this contract are part of excluded category. And I've repeatedly asked to explain what is the excluded category. And they kept.
Can I answer?
Yes.
You have asked that. So we are, and I didn't interrupt David because he was doing a good job in responding, but there's actually new parties who are now responsible for toeing the line on these diversity issues. And so the contract management team is now taking ownership of this. And of course, they report to me. We are going to be revamping the form so that is more transparent and you'll know what's excluded. Typically, it's only things like professional services where we're not, expecting that we're only going to be able to get those from an MWVBE vendor or real estate, things like that. So there's only certain things that are excluded from our calculation in terms of calculating the number on diversity spend, and we are going to revise that bottom portion of the form.
Thank you.
You're welcome.
You didn't tell me to be quiet this time.
You didn't give me permission. That's great. No, that's great.
Do you have a time frame when that would be?
Yeah, we can probably get it done in this quarter. As we were taking that on, we were trying to get our arms around the vendors who are in the space. There's also software that we've purchased to help us with that calculation. And so we just kind of needed to get a better understanding of what actually is truly excluded. A better idea of how to revise the form. So I think, within this quarter is doable for us.
No more. Entertain motion for approval, please.
Move approval.
All in favor?
Aye.
Oppose? Motion pass.
All right. Hopefully this will go a little bit faster. I always appreciate you guys' interaction. The next contract that you have in front of you is for additional license fees from Infor. Infor is the company that we used to refer to as Lawson. And so for our global, our GHR products, our global HR products, as well as some software as a service that we do for them, these are OpEx funds that we did have in the budget for this year because we knew we were going to have to true up our licenses to move forward for the next couple of years. So I put that in front of you for your consideration.
Is that for HR related?
Yes.
Okay.
Yes, this is on the HR side of things. Yes.
And the reason for exemption to the bid again?
Well, I mean, so a longer conversation, which I thought this was going to be a faster one, but a longer conversation is.
I have all the time for
I know you do.
Exemption.
One of Mr. Showalter's big initiatives is working with our HR team to be able to look at what human capital management software looks like for a whole, all of JPS. But that's not this fiscal year thing. It's not even the next 12 to 24 months. It's going to be a really long duration to look at all of the HCM products that we have across the organization. I think right now we have 37 different products that are keeping track of payroll, keeping track of benefits, keeping track of W-2s, keeping track of all of those things. So we're looking to bring that underneath one umbrella. We have to extend these licenses with Infor because we have over 6,500 licenses with them right now. This takes us to
buy time
73.
to do that.
So this buys us the time until we
yeah.
get to that new product.
Okay.
Okay.
Motion for approval, please.
Second?
All in favor?
Aye.
Opposed? Motion passed. Thank you, David.
Thank you, guys.
No, welcome.
Hi there, good morning.
Morning.
I'm here asking for your approval for an exemption to bid for our pricing agreement with AtriCure. The estimated annual cost is $129,200. It is approved in our FY22 budget. This agreement provides ablation equipment, ablation supplies, clips, as well as cryoablation supplies for our cardiovascular surgeons and procedures. Of note, AtriCure is the only vendor that makes this particular device to prevent atrial fibrillation during our cardiac surgeries and procedures. And then we have some additional ablation, cryoablation products that are also used with the same equipment that we have in our operating room that our surgeons utilize.
Any question? No question?
Second?
Thank you.
All in favor?
Aye.
Opposed? Motion passed. Thank you.
You got it all out the way for me.
Thank you.
Item F has been asked by finance team to be pulled for next month. And
Okay.
I'm going to withhold my comment on that one, give you guys the opportunity to come back next month. It's just one of those things where I don't think we like as a hospital to be dictate how much an insurance company should be paying us during the time when we're going through the pandemic, and to keep our population safe. There's an economic behind the admixture of vaccine and drugs and all that stuff, and the timing, the staff time, putting them at risk, and the reimbursement looks like a joke to me. So we'll send it back for revise.
Okay.
I think that goes for all of the large insurance companies that are trying to play game with health system, and that we're trying to keep people alive here.
Okay.
Item G.
Gee.
Hello. How are you doing this morning, Mr. Bender?
Morning.
I'm here to ask for you to consider approval of an exception to bid and pricing agreement between Medline Industries and Tarrant County Hospital District. It is a cost of $97,000 on an annual basis, which is in our budget. And actually, this new contract would allow us to save about $10,000. The underlying reason for the need is that due to supply chain disruption, our current supplier is not able to supply us with the adequate supplies for these blood transfer devices, which are critical to operations and would be a safety concern if we could not obtain them. So this agreement would allow us to tap into a new manufacturer, Medline, that is going to begin manufacturing the tubes and make them and allocate a supply to us so that we have adequate supply going forward, starting in August.
Oh, I see. Before we vote on this one, I made a mistake on item D and item E. Your motion should include the exemption to bid also.
Oh,
I just want
okay.
to clarify that also.
All right. Okay.
And entertain motion for approval with exemption to the bid also as well.
All right. Move to approve the exemption to the bid and for the network pricing agreement between Medline Industries and Tarrant County Hospital District.
Second by, all in favor?
Aye.
Opposed? Same sign. Motion approved.
Thank you.
Item H, we have a lot of exemption to bid.
Yeah, they are all exemption to bid today.
What is your reason for exemption to bid, ma'am?
Got my notes right here, and the contract, DT, in case you have an additional question. Good morning. So yes, another exemption to bid for an agreement with MedShorts. MedShorts is a marketplace, so an intermediary platform that connects pharmacies with wholesalers who have short shelf life product at a reduced rate. So our team would be able to actually go online, look at our cost, and then see if there is a cheaper option that we will utilize from a volume perspective, and be able to procure that. Another good thing about this is, as we've seen through COVID, we know we need to continue to diversify our supply chain opportunities from procurement. We've seen allocation occur in certain areas with wholesalers, so this gives us another opportunity to procure the drugs. And so I heartily support and ask your approval for this exemption
Is
to
this
bid.
the one that's bi-directional, like our stuff with a shorter life can be on there too, or just a one-way in?
I'll have to verify on that. What I know is that we would be, one way is what I understand, but I can confirm that.
Okay.
When you're talking about short life, are you talking about 30 days, 45 days, or longer? Or?
I don't know the exact day timeframe, but I do know, as far as our team is concerned, we would be looking at to assess to say whatever we get here, we will be able to utilize in that timeframe based on our volume, which would make sense for us to make that purchase, whatever that timeframe is.
Okay.
It could be 30, 45. But I could find out. I'm sure my team is listening and texting me. My phone's at that table.
It's a great idea to save costs. I just wish we can do the same if we have extra inventory that have a short life.
No, and
we can
I
put
think
that
that's absolutely, and so we try to actually work locally within the county, within the collaboratives here first to serve the county. But yes, that's a good point, DT.
because we can't put it on eBay. No.
Nope.
Okay.
We entertain motion for approval.
Okay. Move to approve the exception to bid and for the MedShort participation agreement. Okay.
And second by Mr. Zimmerman. All in favor?
Aye.
Opposed, same sign. Motion passed. Thank you,
Right.
Joy.
Okay, and I am here as Zelia Ball today. Is out, and I'm happy to support my colleague, do anything for her. So I'm seeking your approval of an amendment to the professional services agreement with MHMR. This agreement will allow for a supplement of authorized bed days for MHR to use for patients that are requiring inpatient mental health commitments. So.
This is that agreement, okay. Move approval.
Motion, not motion. Oh, in favor?
Aye.
Opposed, same sign. Motion passed. We have a question for you, Zelia. Want to be? No, I'm just
Go
kidding.
ahead.
No, I don't have any question.
We talk all the time. I'm sure she's listening and texting right now, DT. All right.
Don't know if I want to sit in the chair.
We did that contract with MHMR, but if you go and look, they do comply with our MBE, WBE policy. But here we say that there is an excluded category. That's why that we would look at that when contracts come. Because if you go and look at their
Statement.
group, they would comply with our policy. But we're saying that it's an excluded category. And so I think we maybe want to look at, we would check both blocks more than just that one block, say an excluded category.
So are you asking, and I hear what you're saying, I think you're making a great point there, that we just don't allow them to be excluded, just based upon the fact that they fit into this excluded category.
Right.
But we make every effort to ask them to meet that 25%.
Well, they have, yeah, not that they will meet it, but they have already met it when the contract comes. But I think sometimes we just arbitrarily say they're excluded based on
The category
the
that,
category.
yeah.
So I do want to clarify, and it'll help when we fix the language. When we say they're excluded, we don't mean that we're not expecting anybody that we contract with to have diversity in their workforce or have, a diverse makeup. It just means that from a calculation perspective, they may fit within a category where, again, it'd be like real estate or professional services where we don't always know if we're going to be able to get the spend. So that's all that means. So it does not mean that, because MHMR is not an MWVBE vendor, right? And so, but it doesn't mean that we don't expect diversity for them. So I hear you, and we may be able to check more than one box or at least explain why they fit in a particular category.
But the reason I said it because if the CEO is going to do a report on diversity, okay, they would help the report as opposed to making it look bad because they are in compliance, and that's what I'm. Yeah.
I have a interesting comment here that may get me in trouble here, but some of you might not know about climate change. And Tesla is all electric, so they were able to sell the carbon offset to other companies to buy if they can't comply with certain emission standard. Maybe the one we were talking about earlier on, instead of penalty, they can buy excess offset, diversity offset from another company, and in exchange to allow other companies to ramp up, but they can buy excess diversity percentage from other companies to fund that program.
Yeah, especially
I can
if
see
we're going
Colin
to develop a
looking at
program
everybody
to
going to trip
train
over
people.
compliance here. What do you think, Colin? Okay. All right, I'm going to try to see if we can cover for Mr. Petty today. So welcome, Adam.
Sure. So I'm here to present.
Oh, we have another agreement. I'm so sorry.
Item
We have
H.
J.
I'm here to
Item J.
present item H, the Jacobs feasibility, level 1, level 2 feasibility study for our cogen plant within the bond master plan program. The Jacobs was recommended and approved for award through the executive steering planning and board. It has a 30-day out, is an $890,000 contract, and they have a 25% hub participation through a secondary expert in cogen plant. So
Okay.
Entertain motion.
Move approval.
Any discussion? If none, all in favor?
Aye.
Opposed, same sign. Motion passed. Thank you. For the planning and update for the steering committee, Adam, are you covering that one?
would you like me to do that?
Yes, please. Since
So in the Planning Steering Committee, we continue to discuss the Phase 1 and Phase 2 projects. We're moving forward from issuing RFQs and RFPs. This is a perfect example. We are moving very quickly through design with PEC and the Medical Home Southwest. There will be an update on that to the steering committee. I think it's on the 8th is our next meeting. We are deep into design. The CMAR contracts, which are the construction contracts for the PEC, are in or under evaluation. For Medical Home Southwest, the design meetings and construction schedule with Byrne Postel, that has been approved. And in fact, we just completed the first phase of schematic design. Both projects are on schedule to start construction in the fall.
Really? Okay.
Yes. So we are moving very, very quickly. There will be intermediate bid packages so that we can do that and accelerate the projects. But we are moving quickly and getting ahead of schedule. In fact, the meeting we just had, which Bill Masterton attended with us, it was a 2-for-1 meeting. We moved so quickly, we actually got a meeting ahead of schedule. So we're moving very, very nicely right now. So I'm very pleased.
Okay.
And for those who don't know, Beck and Poteri was selected for the garage by the commissioners. So we're meeting with them to iron out their contract. Beck Poteri.
Beck Pateri.
Oh, really?
So commissioners,
Yes.
settled on them.
Yeah.
So we're moving forward with the contract negotiations.
Yeah, that's true.
And we don't expect any exemption to bid, right?
Oh, the commissioners court's already okay.
Yeah. Oh, yeah, no, well.
Thank you for the update.
You bet.
Thank you.
And you'll have a great 4th of July.
I have just one question. Based on their move and they're going to start construction soon, are we putting some plans together to notify those who frequent the medical home there? What's this called?
South Campus?
South Campus. Those persons will know that in 6 months, 9 months, you'll be going, you know.
That will be part of the communications plan. That will be put together, both that communications externally and then also for our patients to understand. We also will start to we're developing signage so that it will be out in the community saying coming soon. We'll also be here on campus coming soon, that there will be, shifts, and internally our staff will need to know there'll be changes in parking. So there is a huge communication lift that we will be doing that will include our patients. So, thank you.
I don't think we have anything in closed session today, and I'd like to use this opportunity. Yes, sir.
I just want to make a comment here about the consolidations of the Finance and Planning Committee. Number one, I don't see the connect as being something that is necessarily beneficial. Secondly, it tends to obscure what the Planning Committee is doing in regard to the bond program. For example, we got one item on the bond program under finance, but it kind of gets hidden in the scheme of things. So I don't necessarily care whether we keep it together or not, but I'd like to see more distinction between the two. I also think it's time that in our finance reporting, we need to start reporting on the budget and the accomplishments in the bond program. We haven't seen any of that yet. So those are just a couple of off-the-wall suggestions from the left over here.
And Zim, thank you. And I will be talking to Trent about some changes that we need to look at for planning, okay?
Yeah, my point being, this has become more of a planning steering committee report and not a planning committee report. I know there's other things planning's got to be doing besides just focusing on the bond program, and that's kind of getting lost in the shuffle of this right now. So I just think we need to be transparent. I hate that word, but transparent so that people that are outside can see what it is we are or are not accomplishing.
I'll discuss that with Trent when he gets back. But I think what we're trying to do, maybe anything that's bond-related needs to go underneath that. We still can conduct SAM meeting, but move it to the area where it's a different shape between the regular finance and that. But also, and maybe we move some of the activity for planning upfront, because a lot of time we have contractor or other people, it costs a lot for them to sit here, so maybe we move them up front if we have some questions, and then we just move things around to make it flow better.
That's part of the conversation I'll have with Trent. Because I do think that planning is not being addressed at this meeting. And so we are needing to be able to discuss some other things beside, we know we're doing the bonding, that's all we're reporting on, but the overall system is doing some other things, and where are we going? And that is part that we need to have a platform so we can have that discussion. And I'm okay if we want to move it up, but I'm thinking that moving it up, making sure that we have enough time to have that platform discussion, okay?
Yeah.
Noted. Thank you for your comment. Thank you, the staff, the administration, and board member for spending time with our meeting. We don't have anything in closed session, but also thank you for being here representing our county court, commissioner court also as well. With no other items, the meeting is adjourned.
I don't believe we have any citizens speak to us. So, approval of the minutes from the last meeting. Got a first and a second. Any discussion? All those in favor say aye. Aye. All those opposed, same sign. Okay. All right. Reports up. Risk register, Colin.
So I will start us where I always do, which is the top risks as appear on our governance risk register. We did this a little bit different after a discussion last time, where our top tier risks, number 1 through 8, are all of a cybersecurity nature. So as a reminder, these are kind of individual risk groups into what our cybersecurity plans are, cyber initiatives. And instead of just having a top 5 or 6 or 7 or 8 that never really moves, we've kind of coupled those together. We'll talk about these in greater detail in the closed session. We do have a cybersecurity presentation from an audit that we will present for you. Number 9, for inpatient admissions risk up to number 9. We'll also have a detailed report on this enclosed. And then 10, 11, and 12 are lower tier risk. That's why they're 10, 11, and 12. It should be noted that due to number 9, the resource that it kind of takes to manage a corrective action plan, our ability to score the coding and billing based risks has slowed a bit. And so where you would primarily see these in the top 5, top 10, we've been a little bit slow to score those just because I needed to deploy those resources elsewhere. And then there's the tie-in to our strategic plan, which we always want to do with our risks. I always try to bring back to the board what the top 5 was the last time we spoke, which was in March. These are the detailed cybersecurity risks that, again, we decided to couple all those kind of together because we don't expect those to be addressed really inside of the next 12 to 24 months. It's a plan to address all of these various cyber risks, which we'll discuss a little bit later today. So a review of mitigated risks. These are items that we have risk assessed inside of the governance division and determine that we can either accept or they represent low risk to the organization. These are primarily operational in nature. These are things that we probably understood going in weren't going to impact JPS all that much, but that does not excuse us from going around and kicking the tires and making sure that our policies and procedures are in place to make sure that JPS is unlikely to or has a low probability of having one of these sorts of events occur inside of one of our facilities. And so we are just providing transparency to the board that we've looked at these and we're going to move on from them and continue on the risk register. All right.
These are high-risk indicators as given by U.S. Department of Health and Human Services?
This would be likely a enforcement action or an event that occurred at a healthcare facility somewhere in the United States. And so we capture it on our risk register, and then we determine whether or not we're at risk here at JPS.
So we're learning from other people's mistakes.
Exactly,
and just trying to make sure we have safeguards in place. Mm-hmm. Thanks.
103 is a case that the American Medical Association has put out a statement that they prefer that ICE agents not go into an ED. And we have a same or similar policy here. Yeah.
Wondering why they do that. Okay.
I have a big ticket item to bring to the governance committee today. It is the corporate compliance program. A little over a year ago, I had the opportunity to interview with some of the folks seated at the table today, Dr. Duncan, Daphne, Mr. Bose, and some others. And during that time, I brought forward a vision of compliance, which was largely based on newer guidance, which had been issued by the Department of Justice. I provided some excerpts from a corporate compliance program at that time. This is the vision of compliance that I bring to JPS. And so we've been working towards this for the last year, and now is the point where the Executive Compliance Committee has approved the compliance program and sent it to this governance committee of the board for a secondary approval to send to the full board, which is an appropriate way for a corporate compliance program to have been approved. For some context, and this is some direct quotes from the United States Assistant Attorney General, who I recently learned happens to be a former Chief Compliance Officer, so he's rather bullish on the idea of the role that corporate compliance plays inside of any organization, inclusive of healthcare organizations. And what it really gets down to is we want to see a risk assessment that the Chief Compliance Officer has access and resources, and that there's a continuous improvement model of compliance inside of an organization. Again, that's any organization. Some of the things we do well at JPS under our current model, which is a charter coupled to some policies, the compliance officer structure here has always been ideal with the board reporting relationship and the CEO reporting relationship. Our committees, the ECC and this committee of the board, function effectively as is intended. Our approach to compliance education is really actually very well done here. So it's something that my predecessors did very well. Our audit protocols are excellent. They are led by highly qualified people, and Jessica Grigsby, who couldn't be here today. And then we do have a very consistent approach to discipline at the organization. So we're not seeing wild variations when misconduct does appear. That being said, our current compliance model is based on the Office of Inspector General 7 elements of an effective compliance program, which you see on the left side of the page here. This is derived from guidance issued by the OIG in 1998. It was supplemental in 2005, so it is not necessarily recent guidance. It is compliance envisioned in healthcare, primarily concerning itself with fraud, waste, and abuse in healthcare. The idea being that the elimination of fraud, waste, and abuse actually translates to improved quality of care for patients. It is a model which we will continue to use. It's an appropriate compliance model. There's an 8th element now, which is an independent assessment, regular assessment of the corporate compliance program, which we'll layer in. But the newer model is on the right here, and it is the Department of Justice criteria. And I think from our recent experiences, we know that when a regulator shows up at the door of JPS, it is not going to be the OIG, it's going to be the Department of Justice. And they have their own model of how they want their prosecutors to measure compliance program effectiveness. And that is what we're going to engineer our compliance program to accommodate. I think lots of people spent their quarantine periods in different ways. I spent mine putting a very well done 7 elements of compliance program effectiveness, OIG compliance program, through a process control audit against the DOJ elements. And what I found was that a program like that is 40% compliant. It doesn't matter. So when I presented that during my interviews, I was fairly confident that's what we were going to find here, and that's pretty much what we found here when we did our internal audit. And so anywhere I found a gap in that 7 elements program, I added language. And that is the program that I brought here, and then had our director of compliance understanding the organization a little bit better. We took about 8 months to understand how this organization works and made some changes to it, modified it to meet JPS's needs, and that's what we're bringing forward today. So as an overview of where we are today, so COM 9000, which is included in the packet today, is intended to be a traditional 7 elements based OIG program. It does not specifically address OIG special areas of concern, which you'll see a little bit later in a slide here, which are primarily finance, fraud, waste, and abuse related items. So we need to specifically call those things out. It doesn't constitute a corporate compliance program as it was intended to. Normally when you go in to audit an entity like this, the first thing you would ask a person like me for is your corporate compliance program, and right now we have nothing to give them. And so that is what we're seeking to do today. And then it lacks certain content measured by the DOJ as an effectiveness marker. Some of the larger items would be our program right now does not address or is not applied to third parties with which we do business at all, which it needs to be. We need to better define what misconduct means inside of JPS. And then an element that's almost entirely missing is the idea of risk assessment and how we deal with risk. And obviously the first entire component of the new program is all has to do with risk and how we identify risk and how we quantify it. So we need to have all that written down as our guidelines for how we're going to engage in oversight of this entity. I'm going to overview a couple of the changes to the program, which, if you may have noticed from the red line, are quite extensive. We are taking a small document and making it a very large one. So section 1 is all about accountability, the idea that compliance begins with the board's duty of oversight and should cascade all the way down through the organization to everybody else that works in it. The work plan from FY22, which the board approved, contained a lot of our, in fact, I think it's an exact word for word of our risk assessment methodology and quantification model. So it's something that the board has already seen and already approved once. We're just relocating it into the corporate compliance program, which is the more appropriate place for it. And then we want to specifically state that there's accountability for the person in my role for the compliance of this organization. I think there's not a situation with non-compliance that occurs anywhere in this organization of which I am not personally responsible. Tone at the top means the board and the senior leaders of the organization essentially take compliance seriously, that it's not just a program on paper, that it actually works in practice, that we speak about it, that we have transparent conversations inside of this meeting and inside of the Executive Compliance Committee, inside of the Acclaim Compliance Committee. So it really needs to be a commitment from the highest level leaders in this organization to say we're going to behave ethically, we're going to submit claims appropriately, and we're going to do paybacks or self-reports when we find that we aren't in compliance. We are bringing back or maintaining the 7 elements. Again, I explained I added another one. So this is not a change necessarily in structure. We're reorganizing where they appear inside of the corporate compliance program just based on how the OIG's model should operate. We are taking a lot of what was in the existing section 3 of the charter and just relocating it here. So even though it appears as a red line inside of the charter right now, those items were really just repackaged and placed here in section 2 where it's more appropriate for them to be appearing. And then we're adding a lot of that missing content that the Department of Justice would expect to see. So specifically calling out different forms of fraud, waste, and abuse, defining misconduct better. We're going to talk about referral statutes here for the first time in a compliance document, hammering down on what our claims submission process should be and what happens if we do receive an overpayment. These things are all written. We talk about third-party risk, how we deal with that, how our program applies to our third-party vendors. There's a section on joint ventures, mergers and acquisitions, these larger concepts, and then physician compensation arrangements. And so there's, and that's just a highlight, there's actually quite a few more. I think there's 26 new sections in the policies and procedures section here. And it's important that we call these things out because that is the crux of the oversight that we're expected to perform inside of the governance division on your behalf. Section 3 of the new program is all about accountability. We want to make it clear that I am accountable. Every leader here is accountable at all levels for compliance, and that needs to cascade, and that we have an environment that is free of retaliation. I've talked about this before in this room. I am very serious about that, as is Carla in HR. This has to be a retaliation-free environment for this program to actually work. And for that to be the case, employees need to feel that I am personally trustworthy. That is something that our new program requires be measured with somewhat regularity, and that the folks that work for me are also viewed as trustworthy, which needs to be measured. So the perception of the division and how we perform our work and how we provide safety to staff to report issues becomes very important, and it's something the board should take note of. A new section here, and this occurred in the work plan as well, is a tie-in between Acclaim and JPS, and then later the foundation on the next slide. So a more appropriate structure, or most appropriate, most ideal structure, is for Acclaim to have an appointed compliance officer, titled such, that reports duly to myself and to the president of Acclaim, right now Dr. Becker, with a dotted line reporting relationship to Acclaim's board. I think that sets up the Acclaim compliance leader with essentially the same structure that I enjoy here. It is a transparency mechanism. It is to ensure that we are meeting the needs of Acclaim, and we don't want a situation where JPS and Acclaim, if viewed as separate entities, are thinking about risk differently, are performing their tasks differently, are having work plans which aren't aligned. We can't be thinking about risks in different ways. It all needs to be unified. Acclaim will have this compliance officer who will still have the ability to design a compliance plan that is specific to Acclaim if they so choose. It just cannot contradict this program that you're going to approve today. It can supplement it. Yes.
When you said this, person be reporting compliance through this committee?
That would be my hope. Similar to how Miriam and Jessica report out separately right now, that you see them and have the opportunity. Yes.
Okay, good. All right.
What do you mean you hope?
It will. I shouldn't have stated that as anything. That's a fact. I don't need to sugarcoat that one. That is a fact. And then the final section is that the compliance program and my authority would extend to the foundation as a budget which is approved by this board and subject to oversight.
Okay.
So I'll be asking for approval of that larger program a little later on, but I will continue along here in the interest of time and bring back our FY22 governance work plan for an update. We have an IT audit which has been completed. It was 2 parts, mobile device security and cybersecurity and ransomware. We will bring back that enclosed and have an auditor to present for you. We are currently in process of an employee substance use and drug diversion audit, patient receivables and bad debt audits, and then a coding compliance audit with the 2 sections you see there. We have 0 action plans that are due, and if there are specific questions on any of these, I'll take them enclosed. As we move forward and think about what are things going to look like in 2023 as a unified governance division work plan that stretches across the enterprise, of course, we want to maintain this risk-tailored resource allocation model, which is taking a look at the totality of the healthcare environment and determining risk and then quantifying risk. We want to maintain line of sight to the OIG's concerns for hospitals, which you can see on the right-hand side there. This is primarily what the OIG is concerning themselves with. It is how they orient their own work plan inside the OIG, which is one of the things we look at when we determine what winds up on our risk register. For our internal audits going into 23, we want to take a more 365-degree view of the item risk that we're looking at. We do that through these various domains, so we will pick a primary domain for every audit that we conduct, but every audit should at least consider every component that you see here. So we bring to you a full-scoped view of auditing, and we are, I should mention, starting next week we have filled out our staff. We are 100% staffed, and our last vacancy went to an RN who will be able to do some clinical audit for us. So we're adding that dimension into the internal audit division, which we are incredibly excited about. And so, and then we want to make sure that, again, we're taking a look at risk in totality. So you get a view of why we looked at it and how it impacts the entire organization. So I'm asking for approval today of 2 policies. Number 1 is the COM 9000, which is the new corporate compliance program. The other is LD 600, which are conflicts of interest for practitioners policy, which didn't change the policy a lot, although the underlying procedure, we had very good discussion with the med staff on that and wound up in a place that I'm very happy with. I think Dr. Miles was very happy with as well. So I will ask for approval of those.
Any questions or comments before we, do I hear a motion?
Second.
Okay.
I do have one question, though. On your page 30, it's 34 of 124. Under C on that page, have you established your intranet website for employees and others to forward anonymous information to you?
That is the hotline.
Okay, all right. That's the audit?
I'm sorry? Yeah, that's our hotline, which is already in place.
You have your hotline, which they can call.
Yes.
But I can also send you some confidential information on another intranet
Yes.
website?
There is for our hotline, there is a toll-free number, and there's also an internet fillable form option. And it
Okay,
collects
that's the form that you're,
Yep, it
that's
collects
the
the same.
intranet. Okay, that was my question. Okay, all right. I think that was, see if I had anything else marked.
Mr. Chairman, I just have one question about the conflicts of interest practitioner policy. So, Colin, does this also approve the procedure?
The procedure does not require approval by the board.
Okay, so as long as the policy is approved by the board, the procedure can be changed annually if needed?
Correct.
That's all my question. Thank you, sir.
Okay, that's
Any
it.
further discussion, questions? If not, all those in favor?
Aye.
All those opposed, same sign. Passes.
And I thank you.
Okay.
That's a big deal. It's not a small deal for me.
No.
Do you have a LD 600?
Asking for approval for LD 600, the conflicts of interest for practitioners policy.
So moved.
Second?
Motion and a second. Any discussion? All those in favor say aye.
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 All opposed, same sign. It passes. Okay, we do have executive session requirements. So we will adjourn to executive session at this time.
All right.
That would be 12:26. Okay, we're back in open session at 1:26. I don't believe there's any actions out of executive session that we need to worry about. So if there's no other business, I call this meeting dismissed.